This video continues Chapter 24 of OEC 6, Abdominal and Pelvic Trauma, by really focusing on the management of abdominal or pelvic injuries. We'll specifically look at eviscerations and impaled objects in this video. When we talk about management of abdominal and pelvic trauma, we always ensure that the scene is safe and initiate body substance isolation. We're going to focus on our ABCD problems and just consider these life threats. That may be for airway and breathing, putting the patient on high flow oxygen. If we can monitor that with a pulse oximeter, we're looking for O2 saturation between 94 and 99%. As always, circulation issues may present as open wounds, which should be dressed and bandaged. Once life threats have been addressed, put the patient into a position of comfort. For an abdominal or pelvic injury, this is going to be supine with flexing of the knees, reducing strain on the abdominal muscles. We'll activate EMS and transport to definitive care as soon as serious injuries or life threats have been dealt with. For an impaled object, it's like all impaled objects. We want to secure it in place and stabilizing it with some sort of a bulky dressing. You can imagine in the abdomen, this might require even bulkier dressings, and securing it without being able to wrap circumferentially is going to be pretty challenging. If the object is very long and that's going to compromise transport, you may need to cut the object. That could be a tree branch, it could be a ski pole, and that would require a pipe cutter. Keep the impaled object stationary. Perhaps use a second patroller and a second set of hands to isolate its movement and avoid causing further internal injury. In the case of abdominal evisceration, it is acceptable to put the abdominal contents back into a large wound, and that's so that the organs do not dry out. That's more beneficial than leaving them out. If it's a small evisceration, we want to leave the contents out. In either case, if it's necessary, we'll cover the area with a sterile dressing that's been moistened with sterile water or saline solution if available. If you don't have access to sterile fluids, water that is clean enough to drink is possible to keep that dressing moist. Don't allow the eviscerated contents to dry out. In the event where clean water is not available, do not substitute anything else. Use a dry, sterile dressing. And remember to keep the patient warm and treat for shock because of the rapid, significant heat loss that can occur with this injury. In the case of a fractured pelvis, we want to apply a pelvic binder such as a SAM sling that's going to slow down internal bleeding and essentially serve as a soft splint for that pelvic ring. Move any patient with the possible pelvic fracture as little as possible. Commercial binders are going to be better than a homemade sheet binder. The SAM pelvic binder may be superior, but with the idea of moving that fracture as little as possible, remember, don't log roll the patient because it can cause more severe bleeding and hypovolemic shock, as it can dislodge blood clots that are starting to form. Use a bridge lift for a fractured pelvis after the binder has been applied if possible. Don't delay transport if additional personnel are available to help you, and if they're not, bystanders can be coached through the bridge lift for rapid transport in this case. Shock is common in abdominal and pelvic trauma, especially a fractured pelvis, and we want to make sure that ALS is on the way and we have rapid transport. Don't forget to keep the patient warm and provide O2 high flow 15 liters with a non-rebreather. Overall, management is going to require recognition of the injury, specific care for the injury and treatment for shock, followed by rapid transport to a trauma center.